And good afternoon to everyone who's tuned in watching live spine surgery being streamed and broadcast around the world from Deuk Spine Institute, located in Melbourne, Florida. Leaders in endoscopic, minimally invasive, and maximally invasive spine surgery. And I'm Dr. Deuk, founder, CEO, medical director. Thank you for joining us today. As you can see from your screen, we have a picture of what's called the lumbar spine, which is the lower back. And this is a patient with two herniated discs. Hello. Thanks. And what we call spinal stenosis. So if you look at the bottom half of the picture of the MRI, you'll see, and do I have a pointer or not? Will this mouse arrow work? Yeah. All right, so I don't have a pointer, but if you look at the bottom half of that MRI, you'll see some things bulging out, and they're actually pinching on the nerves. Our patient here has horrible back pain shooting down his left leg. We call that sciatica, and the phenomenon of a nerve being pinched with symptoms going into an extremity is called a radiculopathy. So our patient has herniated discs at L4-5, L5-S1 with associated stenosis and radiculopathy on the left side. You can see there's another disc down below that looks pretty much normal, and that's called a pseudo disc or fake disc. It's between S1 and S2, and we're not operating on that disc today. But the areas that I'm going to be operating on are where the nerves are being pinched. In a few minutes, I'll go into the operating room and I'll point them out to you. So today we're going to be performing a Deuk laser disc repair. A Deuk laser disc repair is endoscopic spine surgery. We'll be performing it at L4-5 and L5-S1. And my goal in the surgery is going to be to remove those herniations with a laser to decompress the nerves that are being pinched. My goal for the patient standpoint is to basically cure his back pain and his left leg symptoms. That's what I'm trying to do. Our success rate with the Deuk laser disc repair has been about 95% cure rate. Our long-term studies have shown that patients undergoing the Deuk laser disc repair for lower back pain and leg symptoms have 95% relief of their symptoms at 6 years after surgery on average from the patients that we studied. I've been performing the Deuk laser disc repair for the last 11 years. We've had 0 complications. There's no spine surgery in the world that has 0 complications. We have 0 complications in 11 years with over 700 surgeries performed in the lower back and in the cervical spine, the neck. So for people suffering with herniated discs in their neck or their lower back, the Deuk laser disc repair is an alternative to open surgery. Open surgeries include laminectomies, microdiscectomies, fusions, artificial discs, lateral approach, you name it. There's so many different open surgeries, but they all involve removing bone or removing disc completely and putting in implants made from metal. So removing bone obviously destabilizes the spine. It's absolutely true. You talk to most spine surgeons, they won't admit it, but it is 100% true. After all, what they're removing is part of your joints, and joints provide stability. That's one of the basic functions of joints, is movement and stability. And so for spine surgeons to tell their patients that traditional open surgeries don't destabilize or unstabilize the spine is an absolute lie. And honestly, I'm just fed up with it. I'll be honest with you. When I went into medicine or started thinking about medicine as a young kid, I always thought all the surgeons felt the same way. They were all about taking the best care of patients. Unfortunately, that wasn't true, and I found that many, many doctors and surgeons are just interested in taking care of themselves and not really doing what's best for the patient. So at Deuk Spine Institute, we had about 35,000 patient visits last year, and we always try to do what's best for the patient every single time. And that many times means we don't operate. About 9 out of 10 times we don't operate. We're able to fix problems with needle procedures. Some patients, on the other hand, don't respond to the needle procedures and require surgery. This patient right now is one example of that. Our patient comes from a nearby large metropolitan city. He's actually a physician and did not want to have open surgery done in the big city. So he found the Deuk laser disc repair endoscopic surgery, and as you will see through the surgery, the whole surgery is done through a tiny incision, 7 millimeters. There's no bone removed. There's no destabilizing the spine. Okay? The other problem with open surgery is that there's a lot of blood loss with open surgeries. So patients can lose significant amounts of blood, and they become anemic. They either need a transfusion or they have delayed healing or other complications of anemia. With the Deuk laser disc repair surgery, you'll see we're going to lose about 3 or 4 drops of blood. Our average blood loss is less than 5 milliliters, which is really incredible. There's no other surgery that has such minimal blood loss. Another advantage of the Deuk laser disc repair is these patients don't require powerful narcotic painkillers or opioid painkillers after surgery. Most of them just require some Tylenol and a muscle relaxer, and that's all. Our patients also can go back to work the next day. So this patient could go back to work tomorrow if he wanted to. Fully ambulating, normal, just wearing a back brace to prevent him from bending forward. So there's so many advantages to the Deuk laser disc repair, endoscopic disc repair, over open surgery. I mean, I can't list them all. There's too many to list, but they include an immediate recovery, minimal to no blood loss, no use of powerful narcotics after surgery. It's not necessary, and immediate mobilization and up and back to work the next day. So there's really no other spine surgery that can do that. That's why we're pretty excited about it. We want to broadcast these surgeries so people can see it for themselves. Our patient will probably be discharged home about 30 to 45 minutes after coming out of the operating room. His lovely wife is here, and she'll be taking him home. And hopefully we can do an interview afterwards. In the meantime, I'm going to get started with the surgery. So I'll take questions throughout the surgery. If you have them, feel free to ask me. These sessions are designed to be interactive with the surgeon, and you get to see the surgery done from beginning to end. And we're not hiding anything. We don't edit any of these surgeries, and they're available for you to watch afterwards. So enjoy the surgery. Understand that if you want absolutely the best, least invasive, least painful, fastest recovery, most successful spine surgery in the world, you have to come to Deuk Spine Institute. There's no one else that does this. Agent. I'm back. I'm down in the operating room. And I don't know if we still have the MRI up, Zach. I had mentioned earlier I would...
We do not, sir. We do not have it up currently.
All right. Huh? Why? All right. So for those of you watching, the patient is going to be awake in the beginning of the surgery. I'm going to be talking to him. So you'll hear my dialogue. We actually need our patient's cooperation in the beginning. Good afternoon. How are you? What's bothering you, your leg or your back? Or both? What's that? Shooting down? All right, this is Dr. Deuk Majan. We're going to get started, okay? So we're going to get started. I'm going to put you to sleep shortly, but I need you awake for the beginning. It's very important that if you're feeling any pain or discomfort, just say out. And I'll respond by giving you some more numbing medicine. I don't anticipate any problems. Everything looks good. We're going to get started, but don't move your body, okay? You just lay still, and if you feel any discomfort, say out. I'll give you more numbing medicine. We're going to get started now, okay? You feel a little stick and burn. We're on the left side. We all agree. This is the side where this pain is the worst. That's my hand you're feeling. I'm just pinching you, okay? What's the problem? The pillow on his left leg is slipping. Can we get under the drape over there and take a look? All right, that may be the sequential compression devices that we're using. Can you try to lay flat on the table? All right, good. All right, go ahead and lay flat for me. There you go, just relax. Everything's gonna be okay, all right? That's my finger you're feeling, all right? Just pinching you. A little stick and burn. This is normal. We're just putting numbing medicine, so don't get concerned. Everything's okay. You're doing fantastic. And when we put you to sleep, we're going to tell you, please count to 100 by ones. All right? So are you comfortable now? As much as you can be, right? You're going to have to translate. I can't hear. What do you mean by a bad position? All right, you want to come check the mic real quick? Were you? Just lay still. How's the mic connection, guys? Is there still a lot of feedback? Zach, talk to us.
Still getting the crackling.
Hey, put it back in, please. What's going on? Zach, we need to hear from you. Go ahead and bring the mic closer to my mouth a little bit. There you go. That's about as good as we can do. All right, just lay still, okay?
Seems to have cleared up now.
It's cleared up? All right. I'm going to be talking to my team while we do this, okay? Let's go ahead and get a shot. Lateral view. Let's try to get a true AP. Those spinous processes are off to his right side a little bit. Maybe he's just rotated. Are you flat there on the bed? There you go. That's good right there. Perfect. Just lay still right there and we'll be done very soon. Remember, you tell me if you feel discomfort. Shot. Where do you feel that, Shot? In the shin. Okay, no problem. Is it better? And that's where you're getting the pain down your leg, is what it sounds like. Correct? So you're doing a good job with the X-ray. You see how no, lay still. You can't move, okay? I need you to lay still. We don't need to. Shot. Shot. I want to give me. Shot. Give me an AP. So this is the worst level in terms of osteophytes. You can see the end plate posteriorly is got a big osteophyte. Even anterior, he's got huge osteophytes. We're not so concerned about the anterior ones. You're doing great. Just lay still. Our needle position is perfect. Go back to a lateral view. I could be maybe a half a millimeter lower. That's a great AP, by the way. You see how the spinous process is right between the pedicles? It's like an owl's eye. You're doing good. Just lay still. We're going to be done soon. All right. It's a little overexposed. Where do you feel it? In the shin. All right. You have knee pain? You have a knee problem as well? Shot. The what? Laying in this position. Shot. Huh? He's just very collapsed. Shot. I'm going to try to come in just a little bit lower. Shot. Still in the same place? Toes? Shot. Shot. His facet is quite large. Oh yeah, as always. Shot. We hope from your mouth to God's ears, right? Shot. Is that it? Are you comfortable still? Yeah, I understand. Shot. It wants to go, but you have such big bone spurs. Huh? Don't worry, I know what to do. I've done this a couple of times, my friend Carl. Shot. Are you okay? Shot, give me an AP. Wow. Let's take a look on the AP. The lateral looks good. Go ahead. All right, that's good. That's really good. All right, you're doing really good, by the way. No, stay in an AP. We're going to make a little incision. What is it? Your knee is? Can we pad the knee?
Which one? Which knee?
It has a donut on it?
The left knee.
Here's left knee. Can we just check it real quick? We'll try to make it a little more comfortable. Are you feeling pressure on it, or is it just the position of the knee? Okay. Shot. Shot. Everything's going well, by the way, Doctor. Making good progress. Shot. Once we get to where I need to be, it'll be very quick. Just don't move. You're doing really good. Shot. Give me a lateral, please. We're already more than halfway done. With the part, huh? What's he got? Is his knee straight or is it bent? It's bent and there's a cushion in the thigh? So it's fully padded cushion. It's all right. Shot. 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 AP. So I like how you have the end plate lined up there nicely. Where do you live in Orlando?
Lake Nona.
Lake Nona?
Yeah.
Near the medical city?
Yeah.
Yeah. Do you teach at the medical school there?
I don't teach, I do only research.
Research? Shot. All right, let's go with the lateral view. What is your field of research? I know it's cardiology, but atherosclerosis, okay. Yeah. You're a vegetarian, right? You think that helps? What about alcohol? You hear all these people talking about alcohol and how... Huh? That's what I've heard, yeah. Shot. Just right there. We're almost...
We're going to get you to sleep here very quick.
Almost done. We need your help just a little bit longer. Shot. Huh? Shot. Shot. It's like right there. Oh, he's got plenty of bone spurs. Shot. Do you want us to try to move your knee a little bit?
I'm sorry?
Do you want us to try to move your knee a little bit?
Yeah.
Can you? Which knee is it? The left knee? All right. Better? We can wait a minute for you to... Shot.
So we're going to have you to sleep in 3-4 minutes.
Shot. Are you? Where are you feeling pain? Your knee?
Yeah. I think that gets it.
All right. Just try to get comfortable and let me know when you're comfortable. Just tell me when you have no more discomfort. Let me know. So, huh? You're happy? All right. I think we found the right place. All right. Sorry about that. Was that lay down? We found the first of the bad discs. How bad was that on a scale of 1 to 10? 14. 40. Put that down, please. Yeah, 40 over 10. I'm serious. Yes, of course I'm serious. You put what the patient says. And it's concordant. Sir, people don't believe the disc cause pain, but we know they do, and that's part of the reason so many people in the world are suffering with back pain. Huh? Try to get comfortable, yes. And then I need you to lay flat again. And we're going to put you to sleep. When you wake up, everything will be finished. I'm not supposed to tell you that. It's a secret. Yeah. That's the other disc. We found both. Now you can go to sleep. When you wake up, all the surgery will be finished. Count out loud to 100. Start at 1.
1, 2, 3, 4.
See that tear? The annular tear at 5-1? That's a grade 5 tear. The large herniation. That's why his leg was bothering him. Nice and loud. You're doing great. Stay on the AP for a second. Give me another AP, please. You're doing good. That's just the medicine going in. Shot. I've got to see the guide wire. There it is. Keep counting. You're doing good. I know. I just want to make sure. So, guide wires down, needles out, patient's asleep, and now we can get to doing the actual surgical part. Yeah. I have an Israeli patient who may be watching right now. If you're watching from Israel, I know you're coming out to have the surgery done. But we had a conversation on Friday, and you said that the best endoscopic surgery in Israel could not get into the 5-1. That's because it's the hardest of all. And I've only had to abort one in my entire career of 11 years of doing them. So there's a right way to do it, but there's some secrets to doing it. You're going to monitor a little bit? All right, go. Thank you for your help. I appreciate it. All right, so you can see that the dilator tip is right at the entry to the disc herniation, and we're going to advance the dilator into the disc. There's different beliefs about the way to do the surgery. The way that I do it is starting within the disc and coming out into the frame and shot, as that's the safest way to do it. In my opinion, it's the safest and best way to do it. Take, shot. Take. So we are in the L5S1 disc space shot. And next we're going to bring down the dilator, which is going to be a tight fit, of course. You're doing great. Patient's doing fantastic, by the way, from my standpoint. How is he doing from your standpoint? Great. So for those of you watching the surgery, stop. Stop. I need a new glove, outer glove.
Can I get another 8?
That's why we double glove. It's tight, but I think it's fine. I'm looking for gaps is what I'm looking for. I don't see any gaps. If there's a gap, it traps tissue, and it stops it and keeps it just jams everything up. So I'm happy there's no gap. Unfortunately, I caught the edge of my outer glove. That's why we always double glove in surgery. We do two pairs of gloves in case the outer one gets compromised, like mine just did, which, by the way, is an extremely rare thing, but it does happen, and we're prepared. And that's how you avoid complications, by the way. You spend a little extra money. You pay for a second set of gloves every case, but then when you have an issue where your glove gets torn, you don't contaminate the field, your patient's not at risk for an infection. So it's just about levels and levels of protection and thought that goes into the surgeries to do them right and have great results. So that's what we're all about at Deuk Spine Institute, is best results in the world. That's why we have people traveling all over the world to have surgery. As a matter of fact, we have a patient from Australia having surgery on Thursday. And I have my friend from Israel coming to have endoscopic surgery. We're in, like Flynn. Take. All right, now we have our, basically, folks, the whole surgery is going to be done through this 7mm metal straw. And amazing, huh? It takes special equipment to do this that 99.9% of spine surgeons don't have. It takes special training to do this, which 99.9% of spine surgeons don't have. Shot. AP is fine.
Turn the laser on.
Laser on. You know what to set it at, right? Take your time. Let us know when you're ready. I just need a shot. AP. It's all right. Give me the shot, and then you can play with the fluoro. That's fine right there. Just give me a shot. That's great. Perfect. All right. Fluoro, pull it out. Back it out just a little bit. I'm not sure what you're doing. Yep. There you go. All right. So for those of you watching, can you see this here, Zach?
Yes, sir.
Can you see the metal straw? It's called the tubular retractor. Now look how much blood we've lost. We've lost about 6 drops of blood. That's nothing. And if this patient had open back surgery like they wanted to do in Orlando, he would be bleeding a liter of blood. So one of the advantages of the Deuk laser disc repair is virtually no blood loss. And then now we're inside the disc. You can see the herniation, some of the fragments. Remember, we kind of pushed them in. We push the fragments into the disc, which actually makes it safer and easier to take out. Now that part of the surgery, I have to give credit to one of my mentors, Dr. Anthony Young, who taught me that. One of the best endoscopic surgeons in the world. And of course, the thing about spine surgery that the world needs to know is that when someone gets it right and does a great job, all the other surgeons get very, very jealous, and they don't want to support that treatment, that technique, that doctor. I mean, it's incredibly childish, but in the end, it can affect patient care. And I've seen this numerous times. This is a massive disc herniation, by the way, I'm working on. I've seen it numerous times, every field of medicine, pretty much even in politics. That's the problem with politicians, is they really don't actually sit there and say, hey, great idea, you know, let's work together for the benefit of our constituents, our people that voted us in. They all want to get, woo, they all want to get credit, you know. Look at the size of this herniation, folks. This is incredible. Can you guys see this, Zach? Look at that. No. We're going to bask in the glory of this herniation for a while. Zach, can you see this?
I'm zooming in on it, sir. Where did it go?
Look at the size of that herniation that just came out. That was the big one that was pinching his nerve at 5-1. Can you see it?
Yes, sir.
Perfect. All right, so they were asking me if I was going to do a biopsy. We send all of the disc material to the pathologist just in case, just to make sure that there's no kind of tumor or cancer. It's extra cost to us to do it, but we do it anyway because it's the right thing to do for the patient. And that's, at Deuk Spine is that way. Everything we do, it costs more money than our competition, but our results are second to none. And, you know, I read these articles in the news about Blue Cross Blue Shield signs an agreement with Massachusetts Hospital to lower expenses and costs but not compromise quality. And the whole time I'm thinking, didn't Blue Cross Blue Shield just post a profit of $4 billion? So why don't they take some of that profit and instead of keeping it all for themselves, give it back to the patients in good medical care? But no, we don't. You'll see we don't do a lot of Blue Cross here because they don't pay the bill at all. They fight with us on the back end. Everybody comes in thinking they have great insurance, but they don't because they don't cover anything. All right, can you see this herniation here? Another giant herniation. So all my colleagues are making big incisions in the midline and removing bone. Stop. To get these herniations out. We've taken no bone out. And this patient's going to go home 30 minutes after surgery. Can you see another herniation, Zach? Can you see it?
I'm trying to get a zoom on it, sir. There we go.
Yeah,
Yes, we can.
big herniation. Put your thumb next to it, Carl, so they can see just how big. This is the second big one. Show us the first one. Yeah, can you see both of these? Both of these things? That's from
Yes,
one
sir.
disc. That was the biggest herniation right there, L5S1. You got him?
We did, sir.
I feel like I'm delivering a baby here. My dad was an OB-GYN, but I couldn't deliver babies. It just wasn't for me. You know, nothing wrong with OB-GYN, but it just wasn't for me. You know? But I'm glad I found something I love doing. Unfortunately, I have really disappointed with the neurosurgical community out there because they're all a bunch of honest-to-God prima donnas who are more self-absorbed and self-interested in their own well-being and than their patients. I mean, my practice is all about making people better. They all are about making themselves better. All right, so laser fiber, there's a tear. Hello? If you can't pay attention, I gotta take that phone away. Just kidding. Kind of. Huh? Oh, okay, I thought you were on Amazon. Right? Wow, Amazon, huh? $1 trillion evaluation, massive company, Jeff Bezos, impressive. I don't own any stock, by the way. I'm still paying off debt. But I feel bad for Walmart. Walmart's really not going to be around much longer, to be honest with you. Sears already went down. They filed for bankruptcy again. All right, what are we seeing here, folks? For those of you out there that are interested, this is where all the back pain came from. That's inflammation, inflammatory tissue. This is what I remove with the laser. This is what 99% of spine surgeons don't understand, don't believe in, don't get. They're too arrogant to learn anything new. But this is what causes the back pain right there. So we're going to zap it away with a laser because you can't remove it really with anything else. Sure, we can pull out the fragments of disc herniation with the pituitary, but not this granulation tissue, this inflammatory tissue. This is called an annular debridement. And I just got through submitting a paper for publication, and the reviewers came back and said, well, you're not the first person to describe annular debridement in a publication. And I said, you are absolutely wrong, I am. The Deuk laser disc repair is the first spine surgery in the world to describe annular debridement. No other surgery in the world has ever done that. Now, debridement is common in surgery. We do debridements of wounds all the time when they don't heal. The dead, devitalized tissue needs to be debrided out so that the good tissue can heal. And for some reason, nobody's ever thought about it besides me in terms of this right here that I'm fixing wants to heal. It's like devitalized tissue from a wound, a general surgery wound, and the only way it's going to heal is by going in and zapping away the bad tissue which is what I'm doing. It's called an annular debridement. Again, first described in 2012 in our peer-reviewed publication in PubMed in a free open access journal called Surgical Neurology International. I describe the annular debridement as one of the most important parts of the surgery. And again, never before described. So one of these reviewers said, well, the annular debridement was described in 2015. Oh, bravo. Did you bother going back to 2012? I mean, honestly, these are doctors that are doing these reviews. They're so biased and opinionated, and if it's not their name or their friend's name or their buddy, then they're going to shoot it down. I'm sure if you're a patient, you've dealt with this, you know what I'm talking about. Standby laser. Okay, so we've gotten out the big herniations, and now you can see some of the veins in the epidural space. Okay? And notice how little blood loss we've had. There's some bone spurs here. And honestly, the pituitary just can't get it. So the surgeons who say, oh, laser schmazer, you don't need it, they have no clue what they're talking about. This stuff is so hard, it won't come out with metal instruments, surgical steel. You got to use a laser fiber.
We have a couple of questions.
I'll take the questions in a minute, but I'm going to finish my thoughts. Because these surgeries are being videoed. And I know, folks, you're all watching the surgery today, and that's fantastic, and I want your questions to be answered. I'll do my best. But for posterity, in the future, I'm hoping that calmer, more intelligent minds will be judging these surgeries and basically spreading this technology around the world so that more patients can benefit from this type of surgery. And unfortunately, that time is not today, because there's honestly no accountability on the part of surgeons, very little to no accountability for what they do. And if they screw somebody's back up or their neck up, there's just no accountability. Malpractice claims are very difficult to prove. So that's kind of why we're doing these video broadcasts. We want people to see what is available, so you don't have to just go to your local surgeon and do only what they can do. You can actually find a place around the world that has the most advanced techniques where you're going to get better care, better results, and you can get that better care. You the consumer, can actually go out and demand it, and that's what you should do. All right, I'll take the questions. Laser off. We're done here. I'm going to show you guys the nerve root so you can see it. It's just north of me. Look how red it is. It's all inflamed. It's angry because it's been subjected to inflammation for a while. Let me have the laser back. There's a little piece of tissue I want to get laterally. I'll take the question.
We have a viewer that's asking, is an MRI from April too old for a consultation?
Is an MRI from April too old for a consultation? The answer is no. We want our MRIs to be within 12 months of your determination of what treatment you need. So April's fine. The only caveat I would tell you is that if you've had a major change in your symptoms, scope off. If you've had a major change in your symptoms since April, then yes, we would want a new MRI. But if your symptoms are about the same, in other words, your back pain, leg pain, neck pain, arm pain, if it's about the same, hasn't really changed much, then we don't need a new MRI. But if you've developed, say, like weakness in your foot, and you can't pick your foot up anymore, and that happened in June, then yes, I want a new MRI, because clearly something different has happened, and we need that new information. Otherwise, we'll be potentially operating and treating the wrong thing. Okay? So April's fine as long as your symptoms have been stable. All right, we're going to get in here. I'm putting a little bit of pressure on the muscles because the muscles can bleed a little bit. So they bleed from the veins. There are tiny veins throughout the muscles. Muscles are extremely vascular. Remember, muscles are where we produce heat for our body, and muscles are where we store some glycogen for energy, and muscles need to do work, right, all day long. So they need lots of blood flow, lots of nutrients, oxygen. They have to remove carbon dioxide and lactic acid. So you can get into a position. You're not going to hit my arm, don't worry. Point is, muscles have a lot of blood flow, so I always put a little bit of pressure on the paraspinous muscles just for a few minutes. I don't want a hematoma or blood clot developing in the muscle. If you can prevent that, then the patient will have a beautiful recovery with no pain. If you get a little bit of blood in the muscle, they're going to have some muscle spasms as the blood breaks down over a couple of weeks, and they're going to complain about muscle spasms in their back. So then you're going to have to give them shots. You're going to have to give them muscle relaxers. So it's better to avoid the blood clot by putting a little pressure for a few minutes. That'll save the patient from having a lot of misery and suffering. Okay, so I take my time here. I'm not rushing anything. I'm happy with our progress. We're doing really well. The way you make surgery go faster is by becoming better at it. You don't make surgery go faster by cutting corners. So for those aspiring surgeons that want to learn technique and be great, you have to be great by being good at what you do, not by cutting corners, okay? So I'm putting a little bit of pressure, and I think we're about ready. Let's take a fluoro shot. I think we can bring the table up a smidgen, or drop your fluoro down. Which one is it?
It's all the way
All right, table up smidge. So we've done L5S1, and now we're doing L45 next. Our needle is still there. Our guide wire you can see coming out the tip. Coral, put some pressure here, please, straight down. I'm going to go ahead and remove this spinal needle while I check the fluoro to make sure that I'm not pulling my guide wire out. Shot. The guide wire is in, needle's coming out. And remember, we're going to use the guide wire to direct the dilator shot down to our target zone in the foramen. All the surgery here is being done transforaminal. Trans means across, foraminal means the foramen. Very few surgeons know how to do transforaminal surgery. Literally, probably out of 6,000 spine surgeons in the US alone, probably 20 know how to do transforaminal surgery, at most. So you see the tip of this metal thing is going through the foramen, it's going transforaminal. All right, you can come off. Do we have another question?
Yes, sir, we do. We have a viewer that says, I have had 11 back surgeries. I'm fused
How many?
11.
Oh my Lord, I'm sorry to hear that.
I'm fused
really
solid
am.
from my neck to my rear. Have had the front and back surgeries in the same day. I've had the hardware break 6 times, and my fusion broke 3 times.
I'm so sorry to hear this. This is a shame. This is horrible.
They've had titanium rods, but they now have cobalt rods, and they're wondering, are cobalt rods stronger and less likely to break? And they're also wondering, they're saying their pain level is still high, and they're wondering if there's anything they can do.
Yeah, first of all, I'm really sorry to hear you've had 11 surgeries. Just so you know, my patients have 1 surgery. Rarely out of 100 patients that have surgery, 1 out of 100 will need a second surgery. So for our audience, I'm saying this only because I don't want the viewers and listeners to think that 11 surgeries is okay, because it's not. There's something drastically wrong when you have 11 surgeries. So is cobalt hardware better than titanium? I don't think so. If I use titanium hardware myself, and I think that as long as you have a reputable manufacturer that's producing the titanium, I use something called Alphatec. Alphatec makes really good titanium, and I've been using it for 10 years. I've never had a problem. Okay? I don't think cobalt is better. I don't know if cobalt is more brittle or, or more rigid, but if it is, that could be why it's breaking. A lot of people don't know this, but when you have metal rods and screws put in, you don't want them to be too hard. Hard metals crack, they fracture under stress, under loads. Softer metals have a little play, and they won't crack or break. And that's why titanium, which is actually an alloy of molybdenum, chromium, and titanium metal, they're an alloy, they're a softer alloy, and I think it's better, personally. That's why I use it. As far as what can be done, since we need the scope on. I don't know what you're waiting for, but you should already have it on. I can't see anything because this is in the way. These are all things you've got to have done properly. Like a robot. All right? So, as far as like what's causing your pain, I couldn't tell you without examining you. But I think I know what might be causing. If you're still having back pain, it could be a piriformis syndrome, or it could be sacroiliitis. So sacroiliitis is inflammation of the sacroiliac joints, and inflammation of those joints would cause horrible pain just to the side of the top of your butt crack. I don't know if that's where your pain is. And then piriformis syndrome is a torn muscle in your buttock, very common, and that would cause pain in your buttock. It'd be really tender, and you can have pain shooting down your leg from it. So it's possible that those are causing your symptoms. The other possibility is that you have a failed fusion. I mean, you've already had at least one. That's why you've had so many surgeries. So it's a possibility you've got a pseudoarthrosis or failed fusion. I could tell you if you have that based on a CAT scan of that area. But ultimately, if you want help, come see me. I'm at Deuk Spine Institute. I'm Dr. Deuk Majin, the founder. I will be happy to personally see you, examine you as I do all my patients, and figure out what's wrong with you. So Deuk Spine Institute, come see me. We'll need a CAT scan of the area that's hurting, as well as your MRIs and x-rays, and I will figure out why you have pain. Next question.
We have a viewer that's asking, has this patient experienced loss of strength, heel or toe walking, or loss of reflexes?
So we have a viewer who's saying, has this patient lost strength? What do we got there? Is that some schmutz on the lens? Standby laser? Go ahead and wipe. Has this patient lost strength, heel-toe walking? Have they lost reflexes? Have they lost sensation? That's a great question. I don't have the medical record in front of me, so I can't answer that for you. But most of our patients that have a radiculopathy or a pinched nerve do have one or more of those symptoms. Great question, though. He was using a scooter, right. So he was using a scooter to get around because he had so much sciatic pain shooting down his leg into his calf. He couldn't stand up. This is an incredibly educated man who's a research scientist that's studying atherosclerotic disease at the medical school and health campus over in Orlando. So I've given away the city. And he's been suffering for a long time. He's not wanted to undergo traditional surgery. He's been offered surgery by all the surgeons in Orlando, Florida Hospital, or ORMC, neurosurgeons, orthopedic surgeons. He has access to whoever he wants. But he didn't want a traditional open surgery. He's smart. He figured out that the laser surgery we're doing right now would be much better. So for those doctors out there who don't know how to do this type of surgery, you better learn, because patients want better care than what you're giving them. And they're going to go out and get it, one way or the other, whether or not you approve. Next question.
We have a viewer that's asking, can this surgery be done on 2 herniated discs at once?
Can the surgery be done on 2 herniated discs at once? The answer? Absolutely yes. As a matter of fact, that's what we're doing for this patient right now. We already did the first herniated disc, and we're now performing the second herniated disc. And I will say this disc is the L45 disc, much softer than the L5S1. L5S1 had a lot more bone spurs, was more collapsed, more degenerated. We got 5 minutes left. This disc is softer. There's still scar tissue that I'm dealing with right now. And you can see all the herniated fragments. By the way, people think herniations come out as one big piece. 95% of the time they don't. We kind of got lucky with him where we did have the herniations come out as two big pieces, but the rest of the herniations are coming out as fragments. That's the blue things you're seeing. The white thing is the annulus that I was talking about earlier, and I'm performing what's called an annular debridement. The Deuk laser disc repair is the first surgery in the world that's ever described an annular debridement, and that was published and it's indexed in the National Library of Medicine back in 2012. So we realized here at the Deuk Spine Institute that the annular tear was really the source of most people's pain. Unfortunately, most spine surgeons don't know that. So yes, to answer your question, viewer, there's a piece of herniation right there. It just kind of wiggled out. You see that? Pretty cool. We do 2 discs at a time. We can do 3 discs at a time. We can do bilateral as well if you have bilateral leg pain. Generally, we go on the side in the lower back that the patient is having leg pain or leg symptoms. This patient's having a horrible left leg pain, couldn't even walk, was literally going around on a scooter and literally would basically get off the scooter. His wife would have to put it away in the car. I mean, this back pain, these herniated discs, they rob people of their dignity and their life. I mean, can you imagine? I can't even imagine if I had to have my wife take me around because I couldn't care for myself and have to lift things to care for me. I would be ashamed. And if to know that there's a way to fix it and not get fixed, that's why we broadcast, folks. We want everyone to know that back pain is curable, neck pain is curable. You just have to go to the right doctor and the right facility. Oh, by the way, I'll just say this. 2 weeks ago, we did a broadcast with a spinal fusion that I was performing. We had 20,000 viewers watching. That was a new record for us. So I feel like the message is really getting out. Now look here. This is beautiful. Look at this right here. This is the annular tear, okay? This rip right here in this white tissue, it used to be together. But there's a tear, and look carefully. You see the pink color? That pink color is inflammatory granulation tissue. That is what causes disc pain that 99% of spine surgeons don't think exists. And if you go to them with a small herniation and tell them you're having pain, they'll just tell you you're trying to get out of work. You're trying to get out of life. And they'll tell you to go away because they'll ignore you. No, this is the cause of pain in the back, and it's the cause of leg pain. And shame on those doctors for not knowing that. I had to figure it out on my own. If you care enough about your patients, you'll figure out the right answers for your patients.
We have another question.
Yes.
We were asking, since the L4-5 disc was softer, did the 5-1 herniation precede the 4-5 herniation, and which came first, do you believe?
Great question. So we had a viewer who said, since the L4-5 herniation I'm dealing with right now is like softer and less scarred up, that the less scar tissue means it's been there a shorter period of time. There's been less of an inflammatory reaction and time working on it. What happens is when you get a herniation that's been there for a long time under the influence of inflammation, it actually gets really hard. Like, I mean, if you put it in your finger and you squeeze it, you'll feel like you're squeezing like a toenail or something. It's that hard. But a more acute herniation, like I'm dealing with right now, is soft, like crab meat. And you can pinch down on it with your finger. It's super soft. There's not much scar tissue in it. And what I mean by scar tissue is collagen, type 1. So you'll see, if you watch a lot of these surgeries with us, that there's some herniations that are just, they take forever to zap away with the laser because there's so much scar tissue in them. So can I tell whether or not the first disc I did, L5S1, had more bone spur? Was it older? The answer is yes. Because L5S1, the first disc we did, if you rewind, you go back and see it, it had more bone spur. The disc herniation was harder, thicker, more collagenized. That means it's a much older herniation. And this one here is newer. Now, you can be tricked because somebody can have an old herniation that's collagenized and bone spurs on it. You know, it's been calcified. We call it dystrophic calcification. They can have that, and then they can have an acute herniation on top of it. So they can have an old injury and then a new injury at the old injury site. Because remember, just because you have an old disc herniation that's calcified, there's still more soft disc in your disc space waiting to come out. Standby laser. And so I hope that answers your question. I tried. I can actually tell if somebody has a car accident, for example. A lot of times the insurance company just says, look at the MRI. They've had a herniation for a long time. I can actually go in arthroscopically right now like I'm doing, and I can feel the disc herniation and see the disc herniation. I can tell how old it is. I can't date it to a specific date, but I can tell usually within a few months sometimes of when it happened. Much better than an MRI can. I'm getting a lot of glare off that screen. I think it's this light here. Can we shift it or pull it back a little bit, please? I don't know. Maybe turn it off. Let's see if that helps. No? Yeah, that helped. It's glaring. Okay. I'll take another question, if you have one, Zach. This is the last of the tear right here. And you get to the epidural space. You can see the tear. By the way, this tear wants to heal. It's trying, and this is all scar tissue right here at the tip of the laser.
We have a viewer that's asking, is chiropractic a viable option to explore prior to surgery?
Is chiropractic a viable option to explore before surgery? Yes. Absolutely. Did you touch that with your mask? Okay. 100% of the time, if we have a patient with back pain or neck pain, we want them to try physiotherapy, chiropractic therapy, massage therapy, injections, medication by mouth, anti-inflammatories before we would consider surgery. However, when a patient has weakness in their leg or arm, or they have myelopathy, which is damage to the spinal cord, we don't want to wait for a chiropractor. Chiropractor can actually make it much worse. And if a good chiropractor knows when you have nerve damage or spinal cord damage, they will not do an adjustment. And I know lots of chiropractors that won't do an adjustment. They're pretty smart. They're very well trained. Some of them get a little greedy and they don't care, and they're just going to end up doing it because they want the money. But the good chiropractors, and there's lots of them out there, they won't manipulate a patient or adjust a patient if they have signs of nerve damage or spinal cord damage. So I think as long as you're dealing with pain, it's perfectly great idea to go to a chiropractor. We send our patients all the time to chiropractors, all the time, before surgery. Every single patient that comes to Deuk Spine basically gets sent to the chiropractor for conservative treatment first, along with the physiotherapist and the massage therapist. We give patients the best chance they're ever going to get of getting better without surgery, every time. Now, some patients come here and they've already had chiropractic and physiotherapy. They've done shots. They don't want any more. They just want to be fixed with surgery. And we can accommodate them too. But I always insist that they do get evaluated and treated by a chiropractor if they're dealing primarily with pain first before they have surgery. So great question. Thanks for asking.
We have another question.
This is the last of the tear right here. We're going to zap it away and we'll be done. Yes.
We have a viewer that's asking, is it possible to close the tear in the annulus with this surgery, or is it just to clean up the debris?
So we have a viewer who asked a really good question. I mean, all the questions so far have been really good, but I appreciate you asking. They asked, okay, you got a tear in the annulus, which you're debriding. Is it possible to close it up? And the answer is no. We don't have any tool, anything that can close the annular tear. The problem is the people that have tried closing the annular tear have always ended up putting something there that just pops out, in time. And when it pops out on the nerve. And that's really bad. So they've abandoned all types of annular closure. They just don't work. Someday maybe we will have something better, but today we don't. And I don't put anything. The truth is, you don't really need anything. Your body will heal this. as bad as it looks, it's much better than it was before I got here. And what was keeping the disc and the annulus from healing properly was the fact that there was nucleus material, which is called a herniation, was sitting in there, just keeping it from closing. So I've gotten rid of the herniation, and the annulus will heal itself just fine without the herniation being there. Standby laser. Let me try to grab that. So obviously, I'm doing the surgery. I make it look easy. But there's nerves right next to where I'm working. And they're literally a millimeter away. And if I make the wrong move, I'll cause permanent nerve damage. And I don't want to do that, laser. You got to pull it off that way. I don't want to do that, so no surgeon wants that, I don't think. So you have to just be really cognizant of where the nerves are. I know exactly where they are. But if you've never done the surgery before, which is 99.9% of spine surgeons, they've never done this kind of surgery before, they have no clue where the nerves are. And, that's bad. Because how can you protect something you don't know where it is? Stand by. I think we're done here. I'm going to show you the exiting route is right there. You see that? And it doesn't look as bad as the one below, does it? It's got some blood on it, but that's not inflammation. Very minimal inflammation there. They're just a little bit. The one below at 5-1 was horribly inflamed. And that right there, my folks, will heal itself. We're not doing anything more. We've done everything we need to do. I've done over 700 of these surgeries, but each surgery I usually treat about 2 discs. My average is 2.4. So I've really done about 1,500 discectomies and annular debridements in the neck and back. All right. Again, I'm going to put a little bit of pressure on the muscle. We're finished with the surgery. It went beautifully. I'm going to show you the whole incision. It's tiny, half the width of a dime. And this patient's going to go home in about 30 minutes from now. Tomorrow he'll be up driving, walking, doing everything normal people do, is what I expect. Now, some people ask me, do all the symptoms go away right after surgery? The answer is yes, with the exception of numbness. Numbness usually takes 6 months to a year. And weakness can sometimes take a good 6 months to go away. But the pain I expect to be gone. He may still have some irritated nerve because his was so bad to begin with. But I expect him to be much, much, much better. And by the way, when you talk to most spine surgeons, they talk about fixing your leg pain or your arm pain. They don't ever talk about fixing back pain. But back pain is curable as well. And I expect this patient's back pain to be gone, as most of my patients are. You have some more questions for us, Zach?
Yes, we have a viewer that's asking, how do you know how far to dig before hitting the nerve root, or is the nerve root pushed out of the way?
So how do you know basically how to protect the nerve root? How do you know how far to take the surgery? It comes with experience, just seeing what's worked, how much disc material to remove, how much annular debridement to do. It's really not that complicated, to be honest with you. There's no magic to it. I always make sure that the part of the herniation that was pinching the nerve is gone. All my discectomies look like you just saw. The annular debridements look like you just saw. They all look pretty much the same. And then I always check the nerve to make sure I didn't leave anything touching it or underneath it that could be causing leg symptoms. So I always check the nerves at the end of the surgery just to be sure. You have another question, Zach, from the audience?
Not yet, sir.
All right, great. So our patient is starting to wake up. Our anesthesiologist is here, and he's doing good? Yeah. So we lost probably 3 milliliters of blood. Rather than open surgery, he would have lost 500 to 1,000. Can you guys see this here?
Yes, sir.
You see that incision? That's my finger, my right hand, my left hand, my index finger. Look how tiny that is. All transforaminal. No bone was removed. The only scar he's going to have is the one on his skin. We've done no damage to any other structures. The only type of surgery in the world that can be this minimally invasive is endoscopic surgery. The Deuk laser disc repair is the best of them with the best results. Safest profile and fastest discharge and recovery. I'm going to head over to the conference room and I'll take some more questions and answer them. Great job. Thanks, everybody. Great work. Dr. Santiago, congratulations. Great job. All right, Dr. Deuk Majin here. Thanks for watching. This was a Deuk laser disc repair. For those of you who joined us late, this patient had 2 herniated discs in their lower back, L45 and L5S1 with left leg pain. He's a cardiologist, research cardiologist at the university in Orlando. And like we said earlier, he definitely needed surgery. However, he explored his surgical options, and as many of you know, there are a lot of spine surgeons and there's a lot of different surgical options available. Why do we choose this surgery? Well, to be quite honest with you, this is the best in the world. This is the best endoscopic surgery in the world that's available to treat herniated discs in the neck and back. So basically, this patient did something that I wish every patient would do, and that is educate themselves about the different procedures, the risks associated with each one, the success rates of their surgeons, the complication rates, the type of complication, the likelihood that they're going to get a complication with their surgery. These are all very, very important questions.
Our success rate with the Deuk laser disc repair has been about 95% cure rate.
They don't track it, and they don't want to track it.
Our long-term studies have shown that patients undergoing the Deuk laser disc repair for lower back pain and leg symptoms have 95% relief of their symptoms at 6 years after surgery on average.
So
for
yes,
the
I'm a
patients.
little disenfranchised here as a neurosurgeon, very disappointed with my colleagues. But basically, my relationship with my patients is very different, and I believe in being truthful and honest with them. I have nothing to hide. My results are excellent, which is why I have nothing to hide. If my results were average or below average, I would be embarrassed. I would find ways to fix it and make it better, which is what, obviously, I wasn't a great surgeon to begin with 20 years ago, but I had to learn. And I made a decision and a commitment to go to the best training center in the world at the time for neurosurgery, which was the University of Florida in Gainesville, one of the top neurosurgery training programs in the world. And I left Los Angeles, USC Med School, where I went. I was the valedictorian of USC Med School my year where I graduated. Graduated #1 in my class. For those of you who are in the medical field, you know what Alpha Omega Alpha is. It's the National Honor Society for Medical School. I was a president, and I was a junior member, which meant I was elected as one of the top 5 GPAs in my medical school class. I was actually #1. And so my compadres, Aaron Cohen Gadol and Meron Narfad Rad and Farhad Hajilulu back at USC, we were the top students. And so in our medical school class. Anyway, without digressing too much, I chose to come to Florida to train under Dr. Albert Roten, Arthur Day, Richard Fessler, Bo Friedman, Parker Mickle, and Glenn Rectine, Michael McMillan, Jeffrey Henn. These are all top spine surgeons, top neurosurgeons in the country. And there's one thing that those men are, and that is they're honest. They can be true SOBs and really the meanest people in the world at times, except for Jeff Henn. But they had a lot to teach. And so you get beaten up in residency, but as long as you keep your head up, you'll actually learn a few things. And I was very fortunate to be trained at one of the best neurosurgery training programs in the world because of my GPA, because I was valedictorian, and because of the research that I did. Long story short, I graduated and came here to Melbourne, Florida. My wife and I decided this was the right place. We wanted a nice, clean, quiet place near the ocean, and we found it. Set up my practice 2004, and have really evolved to where we do complex spine, minimally invasive spine, endoscopic spine surgery, and treatments. We now have 70 employees. We have a surgery center. We have an office, MRI scanner, X-ray machine, ultrasounds, EMG machines. We have everything we need to be basically self-contained. And there's a reason for that, folks. And that's because I've operated out of many hospitals, and honestly, hospitals are not places you want to go to get your back fixed or neck fixed. Not anymore. We do all of our surgeries outpatient in the surgery center. Patients go home 2 or 3 hours after the surgery is over. So imagine having a massive back surgery with screws and rods, or neck surgery with screws and rods, or plate and screws and cages. All those surgeries are done here at the surgery center. Everyone goes home within 2 to 3 hours from their surgery finishing. The nurses are usually out of here at 4 or 5 o'clock, and times we'll do 2 or 3 fusions in a day. So all those surgeries that other doctors are still doing in the hospital, and patients are screaming in pain afterwards from the surgery and the pain, our patients are not. They actually go home within a few hours on oral pain medication, the same pain meds that people normally take before surgery. And they're not in excruciating pain. Their pain level is a 2 out of 10 on average. So we're doing things that nobody else in the world can do. We're doing them here at the Surgery Center and Deuk Spine Institute. And that's why we broadcast all of our surgeries, because we want everyone in the world to see just how good spine care can be. We're raising the bar. There is no hospital, no facility. I don't care if you're Johns Hopkins or Harvard or Columbia or the Barrow Neurological Center. You are not doing what we do here. And yes, I'm saying that because it's absolutely true. So I have no problem. I have no problem telling you all that. Why do I say it? Because I really do want there to be an awareness, public awareness about not suffering with back and neck pain. All I see every single day are patients who have lived with pain for years, and either they didn't believe it was curable because their doctor never told them it could be cured because their doctor didn't know, frankly, or they're too afraid of the complications of surgery, and they should be, because I've seen horrible complications, not in my patients, but in other surgeons' patients. People dying, losing limbs, having serious infections, complications, pneumonia, pulmonary embolism, the list goes on. And I'll tell you something, those are all surgeries done at the hospital. And so when you get out of the hospital and you get these spine surgeries done outpatient, the risk goes down dramatically of having complications. We have had the Deuk Spine Institute, we've been doing complex spine surgery now with fusion, screws and rods, cages, multiple levels, scoliosis surgery, kyphosis surgery, reconstructive osteotomies. We've been doing it for 4 years. We've had zero, and I mean zero complications. That means no infections, no nerve damage, no CSF problems, no hardware problems, no dying, no pneumonia, no pulmonary embolism, nothing, for 4 years under my direction. So what that tells you, and it should tell you, is that there's a better way to do spine surgery. It's just a matter of finding that place. So yeah, I'm not trying to brag. Believe me, I'm not. I'm trying to help people, but the only way to help people is to tell them the facts or information that maybe they don't know, so that they can make educated decisions. That's why I went into medicine, was to help people get better. It's always been why I've been interested in medicine, was to reduce suffering and pain. As a neurosurgeon, if you tell people you want to reduce pain and suffering, they look at you funny and they tell you to go be a pain management doctor. So I got through neurosurgery really with the desire to take people out of suffering, ease their suffering and pain, and get them back to a normal life. So that's really what I've been able to create at Deuk Spine Institute. So we're going to have a few more questions now that people have posted. I'll answer them.
First one is, how many of that surgery can you do on a patient in one day?
Well, we have an interesting question. I'm really not sure how to answer it, to be honest with you. Somebody has asked, how many of these surgeries?
I think I'm talking about the Deuk laser disc repair.
Okay, how many of the Deuk laser disc repair can you do on a patient in one day? So I'm not really sure if you're asking, if I take one patient, how many surgeries can I do on that patient in one day? The answer is one. If you're asking me how many Deuk laser disc repair procedures could I do in one day, like if I could cram as many into a day as possible, probably get about 8 and done in a day. We'd be here very late, but probably 8 would be okay. I don't know if I answered your question. All right, so somebody is asking, what's the chance of failure, for example, damaging a nerve, having a serious complication? So, you ask a very good question, and I'm trying to answer it. If you're asking what's the chance that I will fail during one of these surgeries, I think it's extremely low, less than 1 in 1,000. If you're asking if I took Zach here, who does our internet marketing and building our website and social media, if he did one of these surgeries tomorrow, I think the chance of failure would be pretty darn high, probably like 100%. So most spine surgeons, I'm going to tell you right now, if you take 6,000 spine surgeons, 5,995 of them are going to have a complication if they try to do the surgery tomorrow, okay? But there's about 5 of us that can do the surgery safely without serious risk to the patient. That's 5 in the United States of America and maybe 10 in the world that can do it. So this is a very different way to do spine surgery, and it's through a tiny, tiny little hole, and it requires a really good understanding of the anatomy, and it requires that you do everything perfect within a millimeter. And so there aren't many spine surgeons that know how to do that. That's why I say that, okay? I don't know if I answered your question, but I tried. So I'm being asked, have I ever used the Mobic C cervical disc replacement? Yes, I have. I did some artificial disc replacements early in my career, and I don't know what you're going to ask me next, but I don't do them anymore, and the reason is that the results were not great. Now, can you have good Mobic C results? Yes. Are they better than the Deuk laser disc repair endoscopic procedure? Absolutely not. I will take on any surgeon in the world that thinks they can do a better job with an artificial disc than I can do with endoscopic laser surgery. Any surgeon, anytime. I am so confident in the results of the endoscopic surgery over implants. Now, if you're a patient out there or you're a consumer and you're thinking, Mobic C, artificial disc versus endoscopic surgery. Well, I'm going to tell you something. If you look at the evolution of surgery, okay, orthopedic surgery in the world, it always starts with fusion of a joint that's painful. Whether it's a knee joint that we used to fuse, or a hip joint, or an ankle joint, people used to get their joints fused a long time ago. And then fusing joints evolved into cutting out the painful joint and putting in a metal joint, right? So artificial joints then came about, and that became more popular than fusing a painful joint, because with an artificial joint you get rid of pain, but you preserve movement. Well, the final movement and final step in the progress after artificial joints has become arthroscopic surgery, right? So now we have arthroscopic shoulder surgery, knee surgery, abdomen surgery, you name it, there's endoscopic surgery, arthroscopic surgery. It's every single field has it. Even neurosurgery does. Well, guess what? We've moved beyond artificial joints in the spine. We're now at endoscopic spine surgery. And with the Deuk laser disc repair procedure, there's no need for metal. There's no need for artificial discs. There's no need for fusion, no need for cages. All those foreign bodies and biologicals that go into the spine to fix it for the last 100 years, all those techniques, throw them out the window, because the endoscopic disc repair is much, much better. How do I know this? Because number one, I literally trained at one of the best neurosurgery training programs in the world, where we did spine every single day. So I was exposed to all different types of spine surgery. Number two, I continue to learn about every single procedure that's done on the spine, the pros and cons, advantages and disadvantages. And I'm capable of performing all the spine surgeries out there. And so I've done them on my patients. I've seen the outcomes. I know which surgeries work better than others. I know which surgeries have a higher risk of causing pain and suffering for the patient after surgery. I know which ones work, basically, and which ones don't cause harm. And so of all the surgeries I've ever done, which is pretty much every type of spine surgery there is, the endoscopic surgery is the gentlest, fastest recovery, most success rate, and really zero complications in 11 years. You can't beat that. So that's why I recommend the surgery. It's not because I can do it. I recommend it because it's the best. And I have family members that travel from other states out here just to have the surgery done. Not because it's free, but because it's the best surgery there is and they can't get it where they live. Yeah, so do I know how to do a Mobic C? Yes. Would I do one on a patient? If somebody begged me to do it, sure. Yeah, I mean, I'll do it. But it would be against my advice, and it would be against my recommendation. I think the endoscopic disc repair is 1,000 times better, and you don't have a piece of metal stuck in your neck. And by the way, those artificial discs do pop out. That was the biggest criticism by many surgeons early on, in the early days when they were first released in the United States after FDA approval. They pop out, and they cause huge problems. And nobody ever talks about that, because the surgeons putting them in don't want you to know about it. All right, so we have several questions. I'll try to address them all together. Somebody asked, do the patients have to wear a brace after surgery? The answer is yes. I put all my patients in a brace after surgery. So if you're having a neck surgery, it's a neck brace. If you're having back surgery, it's a TLSO brace. That's the one with the plastic up front and back. It's got Velcro straps, easy to take off and on. You only wear your bracing if you have a back surgery. You only wear it when you're up walking around. If you're in bed, sleeping, laying down, you don't need to wear a brace. So how long? 6 weeks. I ask my patients to wear a brace for 6 weeks. There's some exceptions. Smokers, definitely 6 weeks. Non-smokers and single levels usually can do 4 weeks. So just so you all know, smoking slows down healing. It does it because the nicotine is a vasoconstrictor, so every time you smoke a cigarette, the nicotine gets in your lungs, your blood, and it causes all your blood vessels to narrow down and you don't get much blood flow. And so obviously to heal, you need blood flow, right? I mean, most people understand that. So to make your wound heal, wounds are very metabolically active. They require a lot of energy, nutrients, vitamins, salts, inflammatory cells, mast cells, and macrophages and PMNs. I won't even go into the details, but point is, for you to heal from your surgery, you need lots of blood flow. Nicotine and smokers reduce the blood flow, so they have a higher chance of having some kind of complication, but they also have a longer healing period. That being said, I've never had a complication with the Deuk laser disc repair in 11 years, over 700 surgeries done. So I think it's very safe to do even in smokers, but you're definitely going to be in a brace for 6 weeks post-op. I don't get any pictures done. There's no reason to get MRI, X-ray. Patients do phenomenal. We don't bother getting pictures. There's no reason for it. It's a waste of time and money. If they're having a problem, I would consider getting it. But in over 700 surgeries, I've had to reoperate on about 7 patients, so 1%. And that's because they did not follow the rules. They broke the rules. So somebody asked me, what about lumbar flexion? If you bend at the waist, won't you reherniate? The answer is yes. Absolutely. If you have just had the surgery done and you go out and you start bending over at the waist to pick things up from the ground, you're going to reherniate. And you're going to have another surgery done. Okay, so that's why I make them wear a back brace after surgery, and that's why I give people lifting and bending restrictions.
What is the follow-up schedule post-op for someone who was to fly in?
All right, so we have somebody asking, well, if I fly in and have the Deuk laser disc repair, what's the follow-up procedure? We would see you, if your surgery was on, say, Tuesday, we would see you Wednesday morning, and then you can fly out Wednesday night and go home. You don't need any follow-up. You're not going to have any problems. I don't expect any issues. You're welcome to come back and see us. You're welcome to phone call us. But generally, there's no issues with patients, so there's no reason to have follow-up. So we would see you the next day in the morning, and that's it. Then you can fly out. Well, we have a really good question, and I addressed it earlier, but I'm going to talk about it again. Somebody is asking, what is the long-term outcome for this procedure? What's the risk of recurrent herniation and maybe complications? So, great question. Our long-term outcome for this procedure, the Deuk laser disc repair, we have our patients that have had 5 years of follow-up basically since surgery. So these are people that were operated on over 5 years ago. And I wasn't doing a lot of them back then, but we had 45 patients that I operated on over 5 years ago that we had follow-up on. The results were 95% relief of back pain from pre-op compared to pre-op. Okay, so all 45 patients had an average of 95% relief of their back pain that they had before surgery at 6 years of follow-up on average. So the criteria for entry into the study was you had to have your surgery done over 5 years ago, and when we looked at those patients, we calculated their average follow-up was actually 6 years. And so in that group of patients with a follow-up of 6 years, the average relief of back pain at 6 years follow-up was 95%. The average relief of leg pain was 95%. So it was equal. Back and leg pain relief at 6 years follow-up was 95%. We've had 0 complications to date. That's a 0.
Your patient's crying. He said it's the first time in his entire life.
Hold on. I have Dr. Kuppinger, anesthesiologist here. He wants to say something to you all about the patient we just operated on.
Yeah, it's the first time in the patient's life his leg pain has been relieved, and he's crying. He's so happy. So it's amazing results.
Yeah, so Dr. Kuppinger is here. He's doing a fellowship with us. He's an anesthesiologist trained at Johns Hopkins, board certified. And he's going to be learning the Deuk laser disc repair procedure next. He just came in from the recovery area where the patient is, and the patient sounds like they're ready to go home, and he's crying tears of joy. He's so happy because his leg pain and back pain are gone. That's how amazing this surgery is. So why don't we head over to the recovery area and see if our patient's willing to come online and go live with you all so you can see him. Okay?